Hello and welcome to Cadabam's Insights. One more series, one more episode, and one more very interesting topic today. Some of the basic aspects of our life and living. Today, we are here to talk about one of the most fundamental aspects of living, which I do not know how many of us consider this to be a fundamental aspects of living, that is sleep, which is as important, if not more, than the food that we eat. To talk about it, today we have a very interesting personality, Dr. Thejus. Dr. Thejus did his MBBS. After that, he pursued his post-graduation in psychiatry. He has special interest in sleep and sleep disorders, and he is a consultant psychiatrist in Bangalore. Welcome to Cadabam's Insights, Dr. Thejus.
Thank you, sir.
What is the sleep, Dr. Thejus, that every day, every human being, gets in and comes out, gets in and comes out? What is this sleep?
Sleep is a recurrent restful state, physiological state where an individual appears to be non-responsive and unconscious, but even though there is a significant and important mental activity happening in the background.
So it's a restorative in the sense, is there something that is restoring? I mean, there is some kind of a storage happening, restoring. What is happening actually when somebody is asleep?
Restoring, even though when we say sleep, when we say sleep, the body restoration predominantly happens because of the inactivity. But when we say restorative, we are talking about all the mental activities that's being actually energized and rejuvenated for the next particular day.
Is sleep something which is unique to human beings, or does every animal on this planet sleep?
That's an interesting question because sleep is certainly not unique to humans. It says there in every animal, but what's unique are humans are the only one who willfully deprive themselves of sleep. Rest of the animals just follow through with it.
So, which means every animal in this world do go through sleep the way human beings have.
Yes, certainly. When it comes to coming to just the duration of the sleep, as a child, an infant or a neonate sleeps for almost 13 to 16 hours per day, which reduces to almost 12 hours per day by their age 1, which reduces to even further about 10 hours per day by the age 10. And as an adult, an average of 7 to 9 hours per sleep is seen in most individuals. But even the type of sleep drastically changes depending on the brain activity they have.
Okay. So, a newborn is also, sleeping. They're sleeping much more than an adult. Is there a reason why? And
Not only they're sleeping more, their even sleeping pattern is vastly different. A newborn will have anywhere between 6 to 9 periods of sleep. They wake up multiple times and go back to sleep.
so, a baby inside a womb, does it also sleep, or is it awake?
To the best of my knowledge, they are known to sleep.
Okay, they do sleep.
They do sleep, but there is a vast difference in the way they sleep. When it comes to coming back to the neurobiology of why that happens is we do have something called an arousal system. That stem comes from all the way from the brain stem, then it goes to the upper part of the brain, which keeps us awake. That system is not still developed in a baby. So the sleep is not as regular, scheduled, and it's a little more erratic. But as the brain stem develops after 6 months to 1 year, after 1 year, this sleep looks more like an adult sleep. But prior to that, as I said, it's multiple frequent fragments are there, and also the type of sleep is much different.
Different. Okay. When we sleep in the night, uh, we know that we are falling asleep, and afterwards, we don't know what has happened, and we just wake up, and in the middle of the night, we would have had vivid dreams. Some of it we remember, some of it we don't remember, some of it pleasant, unpleasant. Is there a stage, or are there different types of sleeps that people have in the night?
Yeah. There are different stages of sleep to the best of our understanding. That understanding has come from two observations. One, the changes in our physiological state. The second would be the brain wave changes. We call it something called EEG, electroencephalogram, where we record the electrical activity of the brain, and each stage has a very distinct and unique representations in how it appears. When a person goes to sleep, the first stage would be N1, or we call NREM. It stands for non-rapid eye movement. A person's eye activity is very minimal, and this is the first stage where the awareness to the surroundings slowly diminishes and a person slowly goes back to sleep. It's common to see a person having muscle jerks, involuntary body movements during this sleep. The second stage
Is this the phase that sometimes we feel we have fallen down? Suddenly we are sleeping and we feel that, we fell down. The muscle jerks that you're talking.
Oh, yeah. And not only that, this is also the stage certain people, in fact, when we talk about ghost stories, a lot of people report when they're falling asleep, talk about they've seen someone. The fearfulness, all the ghost stories happen in the night for a particular reason, because it's a common time where something called hypnagogic hallucination, the hallucination that appear when somebody is going to sleep, happens. Even though there's kind of partial awareness, but they're losing in touch with surroundings. So it's this perceptual disturbance is very common in particular stage.
So they can have experience things which is not true. That's what you're saying. You said hallucinations.
Yeah, that's correct.
Okay, they go through in this first stage of sleep.
First stage is it's possible. Second stage is where the true sleep, when we say somebody is sleeping, the true sleep starts from there. The awareness for the surroundings is completely diminished. The muscle jerks are completely diminished. And then they start having this restfulness. The starting of the restfulness starts here. The next stage, initially it was divided to N3 and N4, two stages were there. In the recent past, it has been combined to just as stage 3. In this stage 3 is the deepest form of sleep. If we use a layman language where somebody says he's sleeping like a dead body, that they're referring to N3, where he cannot be aroused and to get back to the surroundings. And this would be the non-REM, where the non-rapid eye movement sleep happens. The next stage is much more interesting, because whenever we think of sleep, we think brain is resting. The next stage completely defies that. That is the rapid eye movement sleep. As the name itself says, there is a significant movement of the eye. Here, luckily, the muscle twitching, the muscle movements are completely diminished. So here is where the brain activity is very high, and we have a lot of dreams that we can recall. As to why it happens, there's a lot of hypothesis towards it, but for most people, we know this is where we dream. So the brain activity is quite high here. And this is where a lot of our physiological functions of consolidating the memory happens. So a person who has spent a lot of time studying will have a high chance of having increased REM sleep.
Okay. So for our audience, and to simplify, there is a sleep where non-dream sleep, and there is a dream stage sleep. So broadly, these are the two phases that people go through when they are asleep. Correct. Am I right? Yeah. And does it alternate, or with just one continuous that I go to dream and then wake up, or how does it happen? Throughout the night, the 8 hours, 14 hours that we sleep.
In fact, they have an interesting term called ultradian cycles, where it happens every 90 minutes to 120 minutes. All of it repeats all and over again. So even the density changes in the non-REM sleep predominates in the first half of the sleep, while
the non-dreaming state.
Non-dreaming state predominates in the first half of the sleep, while the dreaming state predominates in the last half of the sleep. So why it matters is, at least the practical aspect of that would be, whenever we see students who often lack sleep during examination, we understand the fact that they're waking up early. The REM sleep, which is important for them to consolidate everything they've studied, is lost. So they put in the hard work throughout the day and they do not reap the benefit out of it.
So for a student, it is dreaming which is equally important, not in the daytime, nighttime, to dream, so that his memory is better and he can be a good student. Then that's an interesting piece of information for all of us. But do we also get into this N1 that you are talking about, which is just falling asleep? And then we move to the N2, the where the person is fast asleep, the restorative phase. And N3, you said, is the deepest part of the sleep where the person difficult to arouse a person. So when you said there is a cycle that repeats, does people also come to N1 stage?
Not usually. It's extremely brief state. It's usually seen in the first cycle when a person from the state of total awareness slowly slips into the sleep. And after that, unless there is a sleep disorder that is making the individual come up all the way to the arousal, usually we do not typically see N1 repeating itself. It usually comes to N2 and the cycle repeats again. N2, N3, dream sleep and repeats all over again. This cycle keeps happening. And to understand where the switching happens, that's where the neurobiology comes into place. As we mentioned before, there is an arousal system that's coming all the way from the brainstem to the upper part of the brain. And this arousal system,
Brainstem is the region of the brain which connects our spinal cord. That's the bottom portion. That is why it is called as the stem, the bottom portion of the brain. And from there, the nerve cells branch out to the other aspects of the brain. Yeah.
I can say one more interesting aspect is, as you mentioned before, when we see a person in coma, that we look like they're also sleeping. That is because there is a damage in the brainstem. The arousal system that's supposed to wake a person up is markedly damaged that they cannot wake up anymore. So this arousal system is active all the time and it tries to keep us awake. Arousal system goes into certain parts of the brain called thalamus and hypothalamus, where there are certain brain chemicals, neurotransmitters, which actively keep us awake. But when the whole tipping over point, as I mentioned, as the sleep inducing substances accumulate, the tipping over point happens. We do have ventrolateral optic nucleus, which is this on switch. When I say on, it means on of the sleep. What happens is there are certain neurotransmitters, inhibitory in nature. We have mainly GABA for that matter. It switches off this arousing center. So throughout the night, we maintain that inhibition of the arousal centers, which induces sleep. But when all the sleep-inducing substances evaporates, for lack of a better word, or dissipates, then the switches goes off, and all the substances which were just waiting to make us awake get us back to the consciousness. And this is called a flip-flop switch. There's sudden awareness for us. The transition from sleep to waking is not very drastic. It's few minutes because it's just waiting to come on again.
It's like a competition between one center which wants to keep the person asleep and another center which wants to awake, and whichever is has an advantage, the person is in that state of mind. What happens, you said, when person is dreaming, the brain is extremely active, and there is a restoration of memory that is happening, and reorganizing of certain the brain neurons also that's taking place. So when somebody is sleeping, which part of the brain is sleeping? Is only some part of the brain is sleeping, or not any part of the brain is sleeping there?
So for this, I would say, like, when the non-rapid eye movement sleep, I would say the whole part of the brain, the activity is pretty less. But
that is non-dreaming state.
Non-dreaming sleep. In the dreaming state, mainly the cortical activity, frontal lobe, everything is quite active, which gives us the vivid dreams that we know. And you did mention about memories, where throughout the day as we go about, the memory is usually stored in a temporary place, not in a permanent place, where called hippocampus. That memory is transferred into or consolidated into a long-term memory during this particular part of the time where the rapid eye movement happens. So even though we say sleeping and non-sleeping, brain is certainly not resting throughout the night. It is still working.
So like heart, lungs, and kidneys, brain also doesn't rest even in it's like none of the areas of the brain rest. That's a important or an interesting piece of information. We generally think when somebody is sleeping, brain is shut down. So how a person gets into sleep is what we try to explore now. But why? You know, why should an individual sleep at all? I mean, is it helping an individual? You see, for food, we need that food so that there is energy. The every cell of the body needs energy, and that is coming from the food that we are eating. But sleep, it is just a rest. Okay, why do we need to rest? Why does the body need that rest at all? Sleep.
Again, this is a question that has been posed in the last almost 6 years multiple times, because as we getting into fast-paced lifestyle, a lot of people see the sleep as a redundant activity. They want to get by without it. Unfortunately, I don't think they've been able to. So when it comes to this question, we have seen a lot of animal studies where deprived animal of sleep to see what happens. Can they make it through? Surprisingly, when the whole of the sleep is deprived, most rats involved in the study died within a 2 to 3 weeks time. And when we try to selectively suppress both the rapid eye movement sleep or the dream sleep, or the non-rapid eye movement sleep or the restorative restful sleep, the rats still died. It was slightly delayed by a month or two, but all of them eventually succumbed to that particular difficulty. So we do know it plays a huge vital function. Now, when it comes to humans, even though nobody's intentionally done a study, we have definitely studied individuals who have deprived themselves of sleep, and we've seen drastic adverse changes. It might be starting from increase in the cortisol levels, where a person feels extremely stressed if
That's
they're
the
lacking.
stress hormone, the cortisol.
Okay. And also their lymphocyte count drastically decreases, which translates to someone's immunity becoming very poor. Then also with respect to the BP changes, the blood pressure changes.
So when somebody sleeps, uh, you're saying, when somebody is deprived of sleep, there are a lot of uh, s- adverse effects on the human physiology or the health of the individual. Like the brain is restoring itself and rejuvenating itself during the sleep. And it looks like sleep is primarily a brain related activity, or can I say that, or it's a total physiological body?
As I mentioned in the beginning, even though the best of our evidence, they say as long as physical rest is given for the body can still compensate, because it can still clean up and still restore itself. But when it comes to brain specifically requires sleep. So resting won't cut it.
Okay. uh, I think we digressed when we were talking about the effects, the normal physiological effects of sleep on the body. You were saying the heart rate goes down, and person uh, there is restoration of removal of toxins or the unwanted chemicals from the heart that's happening. What happens to our respiration, breathing, and does our uh, digestive system also work in the night, or what restoration happens in those organs?
Respiration also comes down to relatively much more stable, with again, even the relative resting state. When it comes to digestion also, it does slow down. That's one of the reasons we request individuals not to eat 4 hours prior, 3 to 4 hours prior to sleep, because we do make sure that our organs also rest. So when it comes to every organ, even though they don't shut down altogether, they all go to a relatively resting state.
So it's almost like a basic, basal functional level that, almost our organ gets into, except the brain, which is, as you say, is
Every other organ tries to do the least amount of work during that time.
okay. So when somebody is not sleeping, okay, we will get to the reasons for not sleeping. But when somebody doesn't get sleep or is not sleeping, what are its adverse effects on different organs and, on the overall of the body?
Okay. First, before we start with what happens with somebody depriving themselves for sleep, I would want to make the distinction between acute changes that happens, as in somebody just sleeping not for a day or two,
Okay,
and what happens if somebody deprives himself for sleep for a very long time.
long time. Okay.
Usually, it is understood if a person does not sleep for a single day, and if they try to compensate by sleeping the very next day, most part of it can be recovered. But when I say most part of it, I would say anywhere between 30 to 50% of the brain changes can be recovered, not 100%.
So even a 24 hours of sleep deprivation can damage the brain.
Definitely. So it cannot be completely restored. Again, to be more specific, only about 30% of the rapid eye movement sleep and almost 50% of the restorative non-rapid eye movement sleep can be recovered. So not all of it for sure. So when the person,
I mean, this is a very, very crucial, piece of information, which we neglect it. I mean, we think that, oh, what happens even, I mean, one day we don't sleep or 2, 3 days we don't sleep because we are engaged with something. But you're saying the damage can be permanent one, in the sense, the recovery can be only 30-40%. The damage.
in fact, one of the biggest mistake most people in urban areas do is they deprive themselves of sleep throughout the week, and they say they can compensate on weekend by sleeping for 3-4 hours. That doesn't happen. In fact, that has been, whenever they see that, one of the observation everyone might have noticed is, even in spite of sleeping adequately in the weekend, when they wake up, they might not exactly feel fresh. They might feel still groggy, which is very puzzling. There's like, I slept for 10 hours today compared to 6 hours. Why am I feeling still sleepy? That's because a sleep inertia builds up. They still don't feel fresh because body is still craving for more sleep. So damage certainly cannot be undone by a weekend sleep. And coming to the chronic sleep deprivation,
I think the acute, short, one day of not sleeping or couple of days of not sleeping, its effect on the body, adverse effects on the body. I think you were talking about it, then we digress. Sorry.
yes, sir. So coming to the chronic part of it is where again cortisol shoots up, the stress hormones are very high for a person. And when this continues for a long time, this is what it results in the flight or fight response a person activates. So even once it starts activating in the future, it might present like an anxiety. It might present like somebody's having bad nightmares. It might present with sleep paralysis. So what has been a short-term problem, primarily due to sleep deprivation, becomes a long-term problem. And also, when the cortisol is very high, our body gets into a stressful state where it derails our glucose regulation altogether, which increases the risk of somebody end up having something like a type 2 diabetes mellitus, or somebody is having increased lipid where they go into dyslipidemia, where the lipid profile is completely deranged. And also, their lymphocyte count, the blood cell count becomes very low, their immunity is very low, so they have frequent infections, frequent fever episodes, extremely common to see that. And also there's a part of the brain called amygdala, which is the emotional processing center, and this particular center is also activated to a greater extent. Even though it's necessary for a function, a greater activation means a person is having mood disturbances, mood fluctuations, irritability. And also the cortical function, the frontal lobe, which is the part of the brain which involves in the judgment, planning, and making very quick decisions certain times, attention, concentration. Since all of it is hampered, they will not be able to learn things, they'll not be able to organize things, they'll not be able to concentrate on things. In fact, the effects of sleep deprivation is seen, the fact that 1 in 6 accidents seem to be attributed to sleep disturbances. And also famous disasters like the Chernobyl or the Challenger, the space shuttle explosion, all of them had components where individuals with sleep deprivation worked on it, unable to fulfill the work in the adequate amount, and that resulted in huge disasters. So sleep deprivation should not be taken lightly at any extent.
Okay. Why does this sleep deprivation happen at all? This is such a normal thing. Every human being needs it, and we have to feel hungry. So we have to feel sleepy. I mean, we should go to bed, we should get sleep. Why do people not get sleep?
This is definitely a complex question. So coming to it, let's look at the definition of what insomnia refers to.
Okay. Insomnia is
The
No, sleep disorder, or is it different? I mean, lack of sleep.
I would probably call it a sleep disorder.
Sleep disorder.
Disorder. But it has a very particular set of definition which is interesting for other reasons. It says about how an individual is unable to start the sleep, maintain the sleep, consolidate the sleep, or unable to wake up fresh, which results in a lot of difficulties in the day-to-day activities. But the caveat, the reasons they give is the fact that it should be when the person has adequate opportunities for the sleep. But in this day of age, a lot of people might not meet the criteria for insomnia. That doesn't mean they does not have sleep deprivation, because I don't think we are giving the adequate opportunities. We willfully are depriving ourselves of good opportunities to sleep. So when we say why it is happening, it's a multitude of reasons.
Multitude. Okay. And what are the reasons for this sleep disorder or insomnia that we come across?
Uh, Again, coming to insomnia per se, particularly, there is usually something called a primary insomnia and a secondary insomnia. Surprisingly, what I mean the primary insomnia is there are few people who have sleep difficulty, even though when all the aspects are still well maintained, it's purely a problem with the brain. That's often is hereditary in nature. Almost 65% of our sleep difficulties, mainly the non-rapid eye movement sleep difficulties, are hereditary in nature. Other aspect of it, it's also seen the people with insomnia, primary insomnia, also have 30% less of the brain chemical that induces sleep, the GABA, is 30% less. So it's understandable why they would have primary insomnia, but the bigger chunk is actually the secondary insomnia. Secondary is due to another cause. It might be a physical illness, it might be a mental illness. Due to a secondary cause, they might not be having sleep difficulties. So the causes we can definitely enumerate. Coming to
So you're saying the sleep pattern or the non-REM, that is non-dreaming part of the sleep, can be genetically inherited.
interpretation of dreams came out by Sigmund Freud. He has documented an extensive amount of dreams and tried to understand as to why we dream, what is the importance. So what we have understood by so far is dreams can often have a symbolic representation of the day-to-day activities, the stresses, mainly the unconsciousness, the voices that we have, which is not overtly expressed in our emotions, in our speech, is often represented, or hidden desires. So it's seen that a person going through a stressful event, the processing of it to help definitely happens in dreams. And also the fact that on the coming to the neurobiology side of it, it is seen the brain plasticity, as in the fact that brain has the ability to learn new things, and the new stimulus is actually provided by the dream. Even if we sleep, there is basically a cinema going in the brain, helping us, keeping us entertained, keeping us learn new things. So dream plays a huge role, mainly when it comes to emotional processing. And when it comes to interpretation of the dreams per se, again, I cannot think of a solid way of interpreting it, but depending on each client or each person we talk to, we try to understand what it means to them and what is the day they went through, and we can certainly understand the stress factors underlying it.
So, as an individual, uh, as people, when we dream, should we attach any importance to the dreams that we have, or just ignore and move on with life?
I would definitely attach importance, a personal importance, the fact that a person should ideally document the dream
Okay.
and probably have a magnifying lens at it and try to understand it better. So I would definitely not say ignoring is the right way to go about. We should definitely try to understand. If you want to understand yourself better, understanding your dreams is definitely a pathway.
With the different kinds of, insomnia or sleep disorders that, you are talking about, does this non-dreaming sleep and dreaming sleep significantly change, or it's all the same there for the different types of problems?
It changes according to different type of problems. And coming to the main reason as to why we as mental professionals are talking about sleep is the fact that by so far, to the best of my understanding, there is not a single psychiatric disorder where the sleep pattern is normal. that just pretty much never happens. We always have illnesses which various degrees of sleep disturbances. To start with,
Sleep is a very significant problem that you encounter when you are seeing a person with mental health problems.
In fact-
Most of it. Yeah.
in fact, whenever I am talking to the client, it might be a client with a psychotic illness or a mood disorder. When I'm psychoeducating the family about it, I always tell them, if sleep goes bad, you meet me immediately, because it always acts as a precursor for the whole illness to come back again. So it might be 3 to 4 days of sleep disturbance. I know the person is having an episode next. So coming to the mood disorder, we know when it comes to something called an REM latency, the time it takes for us to sleep and having the first REM cycle, the sleep latency is markedly reduced. As in the fact that they have REM very soon, which is not ideal because we have the predominant rapid
Dream sleep coming early.
Yeah, dream sleep is supposed to come in the later half of the day and not so early. And also, it is huge. And the total sleep time for a person with mood disorder is decreased. They wake up multiple times. And the restorativeness is not there because the non-dreaming sleep is pretty much less or very absent over there. So when it comes to a person with
So with what you're saying is, in different sleep disorders or insomnias, this phases of sleep itself is disturbed. The phases of sleep itself is not happening as normally it should happen.
That's very much correct. It's markedly deranged. So whenever we do think of a treatment, we do the helping the core illness. One of the way we can understand it's improving is because the sleep patterns also start improving.
Okay. So when should we come to you? See, sleep is such a normal thing. Of course, when somebody is not getting sleep for days on end or weeks, naturally they are concerned, and they'll obviously come to you asking you for problem, and then you'll be able to help them. Much before such a big problem, are there early stages where, as a normal individual, I can recognize, okay, maybe there's something going wrong, and I can approach you?
So the daytime symptoms, the daytime problem a person faces due to sleep disorder can be a very good red flag for them to approach a clinician. It might be as simple as unable to concentrate. When they wake up, they don't feel fresh. In fact, they want to go back to the bed. And throughout the day, feel very lethargic. Throughout the day, they feel very irritable. And all this, and they're unable to organize themselves. They feel very haphazard. And when all these difficulties in the daytime, their functionality is markedly hampered. They feel so lethargic, they're not even interested in having a conversation with their individuals. When the daytime symptoms amplify, the functionality of an individual is hampered, that might be a good time for you to approach a
Condition to in the normal phases of sleep, are there any red flags or alarms that we should be worried that I'm dreaming more, or I'm not dreaming at all? I mean, it's quite common. I don't know for whether there is a scientific evidence for this. There might be days that people might not have dreamt. I don't know whether that is a possibility.
It is definitely a possibility.
Yeah.
As I was mentioning before, usually whenever we see an REM, the rapid eye movement of the dream sleep, if somebody is learning new information, it's understandable it will translate to the rapid eye movement or a dream sleep. But if somebody is involved in physical activities, physical exhaustion, that is where the non-dreaming sleep increases. So it's understandable if a person is not dreaming, there is a possible correlation, the fact that they might not be actually learning a lot of new things, possible correlation. And if a person is having a lot of NREM, that means physical activity is quite high. That's something we can, again, it's an indirect correlation because there is one more aspect that we should take into consideration. That's called the chronotype.
Okay.
Why I'm telling that is because even though we discussed about how the sleep is different in different age groups, what we did not focus on, what about a person with the same age group? They can still have different patterns. That is where chronotype comes into place. Chronotype is way naturally a person has a cycle or a rhythm that is slightly, there is a change in each individual. Often we say a night owl or a morning lark. That is the changes we are talking about it. So understanding a person's natural cycle also plays a huge role, and also it also changes the type of sleep they might have.
Okay. I didn't want to, complicate as normal thing of life as sleep. Uh, we have complicated our food system so much that as people we are so confused what to eat, what not to eat, how much to eat. There is so much of information available, so many different point of views and so many opinions that is circulated outside. It confuses people. So especially with sleep, I didn't want to confuse our audience by saying if you don't have dreams, if you don't, or if you have too much of dreams, come and consult a psychiatrist. That's not what I meant. But uh, a very important thing that you said, that if there is a problem in the functionality of that particular individual, he is not very active after the sleep, he is not able to do the normal functions that he was earlier able to do, and he's irritable, and his concentrations are is not as able to concentrate like before. Some of those normal aspects, if there is any problem, maybe it could be because of the sleep, and it's better to consult a professional. When there are problems with sleep, one of the other biggest confusion is, who should we consult? you know there are so many specializations, so many professionals available. Who is the right professional? Whom should we consult? Of course we'll come to you, but whom should we consult?
Uh, for that, I would like to briefly just talk about what might be the type of sleep disorders, because the specialities that's involved with each might be slightly varying.
Okay.
As per the International Classification of Sleep Disorders, Revision 3, the first classification is insomnia itself, and the second classification is sleep-related breathing disorders. And the third category would be increased sleeping, hypersomnolence, which can be seen in something like a narcolepsy.
Okay.
And the fourth is the circadian rhythm disorders. A person is feeling sleeping too early, or he feels like he wants to sleep too late. Also, his sleep is very fragmented. And also the fact that sometimes people with who is doing night duties altogether, their shift is completely changed. These people present with a specific type of sleep disorders. The next type would be called parasomnias. Parasomnias often refer to an bizarre behavior associated with sleep, with either partial arousal, and they might do certain acts with no recollection. So these constitute parasomnias.
I think we will there are so many individual sleep disorders that you're talking about it. I think it looks like a very exhaustive and a very detailed discussion that we are going to have now. You're talking about different kinds of sleep disorders, insomnias, where the biggest confusion that we were trying to address is, there are so many sleep disorder specialists, whom to approach when. And you did talk about, there are sleep disorders related to basically the aspects of sleep, and then to the respiratory system and rest of it. Can we dwell into each one of it in details so that it will be very interesting?
Sure, sir. For that, a basic sleep assessment has to be done. After that, probably a referral to the appropriate specialist would be better. When I say sleep assessment, it involves a detailed history taking from the patient with respect to the have difficulty with sleep, initiating the sleep, maintenance of the sleep, or do they have lack of freshness when they wake up from the sleep? Do they wake up multiple times in the sleep? Do they wake up with a dream, or do they wake up and don't recollect why they woke up? Or we also discuss things with their partners with respect to what kind of movements do you see in his body. Does the patient is known for snoring? Other than that, we also take a detailed history with respect to, are they using any medications, are they using any substances for intoxication. So after a detailed history taking, we can probably have a better understanding who would be the right specialist to refer. When it comes to insomnia, uh, we can definitely think about both psychiatrist and sleep specialist. When it comes to sleep-related breathing disorders, pulmonologists would be the first clinicians to see.
Okay. So, what are these different insomnias or sleep disorders that you generally come across?
On a day-to-day activities, insomnia,
So, the different types of sleep disorders that is there. What are the different types of sleep disorders that you generally see?
the classification.
Yeah. Yes.
Okay. The different types of sleep disorders are, the first is insomnia itself, where a person is unable to sleep, have a sound sleep with sleep initiation, maintenance, consolidation, and waking up not feeling fresh, in spite of adequate circumstances and adequate time given to the individual, and this resulting in day to day difficulties as he goes about. Second would be sleep related breathing disorders. In the sleep related breathing disorders, for various reasons, the person's breathing is altered or hampered. It might be due to some difficulty in the way the brain works, or it might be a physical obstruction a person might face. Either of it results in a small period of time where either he's unable to breathe or has a very restricted way of breathing. So the lack of adequate oxygen in the body stresses the system, so it results in episodes called RERAs, that
RERA.
RERA,
Okay.
respiratory effort related arousals. As in, because the patient is trying to consciously take breaths, as in when we discussed about the physiology of sleep, we know the respiratory system goes to very minimal effort. Now we know that minimal effort is not going to suffice anymore. There's an active effort he needs to bring so that the person partially wakes up or completely wakes up, often gasping. So this particular thing causes a lot of sleep disturbances. The patient keeps coming back to stage N1, which is not supposed to. So the next would be hypersomnias, where there is excessive sedation. When we say excessive, we are primarily talking about excessive sedation not in the night, but rather during the day-to-day activities. They suddenly go into episodes of short bursts of sleep, which they feel refreshing when they wake up, usually in conditions like narcolepsy. Then we have circadian rhythm disorders. When we say circadian rhythm, it's basically an internal clock we have that maintains the 24-hour cycle that a person goes through. And it not only manages sleep, it also manages a person's hormone level, their body temperature, and it takes cues from the outside environment as to if we are when do we eat, or are we exposed to a particular light. So when any of this is altered, the outside cues is altered, or the internal clock is mismatches there, they'll end up having either a delayed sleep cycle where they cannot sleep for a long time, they wake up very late and wake up very late, or in a person inoperably, they might end up wanting to sleep at as early as 7, which might interfere with their social engagements. So either of it can be problematic. And also the shift worker issues, as in a person who's having a night shift rather than a day shift, their circadian rhythm is completely altered. These people present with the circadian rhythm disorders. Then we have parasomnias. Parasomnias can be of both types. It is seen in the dream sleep, it is also seen in the non-dream sleep. But the ones that happen in the non-dream sleep are quite severe, where there is partial arousals with confusion, or with respect to they might act a particular way. It might be sleepwalking, or grinding the teeth, or a child might urinate on his bed with no recollection of doing that. So these all constitutes parasomnias. Then we also have sleep related movement disorders. This is primarily a signifier of some underlying neurological conditions, but it can happen independently also. It's more than for the patient, it's a huge problem for the partner, where they end up hitting or kicking the partner, and they wake up multiple times and they still in the morning they have a non-restorative sleep.
Okay. What are the reasons? I mean, are there causes, known causes for each type of sleep problems that you just mentioned?
Definitely,
Okay.
there are reasons for each type of sleep disorders. Coming to insomnia per se, insomnia, as you mentioned, mainly multiple what do you call that? Mental disorders can definitely result in insomnia. When we say, it might be depression, it might be anxiety disorder, it might be schizophrenia, it might be dementia. All of them can result in a condition like insomnia. In fact, the relationship is so important, mainly when it comes to schizophrenia, where there's one of the very few conditions where a long-term sedative is usually indicated. For most individuals, we wouldn't prefer giving a long term. The reason being, there is a relationship between their non-dreaming sleep and the size of the brain. If their NREM sleep, the non-rapid eye movement sleep, has a drastic decrease, the shrinking of the brain becomes very rapid.
Are there any tests that needs to be performed to help aid in diagnosing that there is a sleep disorder?
Definitely. One of the basic tools we do use in our daily OPD services, outpatient department services, is multiple sleep scales that we give to the client. We help them rate it themselves to understand what part of the day is been affected, how their sleep has been. So we do get a general idea as to what kind of sleep disorder they might have. But often that might not be sufficient. So we have to go for investigations like polysomnography. Polysomnography is done in a sleep lab where a person is made to sleep for a distinct period of time where all the body variables are measured. It might be heart rate, their oxygen saturation level, their respiratory efforts, and there's also video and audio where we can know if there's a body movement, if the person is making any sort of sound, and also we see the electrical responses from the skin. A detailed assessment is done in a time-stamped fashion, so we know what stage it the person had difficulty corresponding to the what type of brain wave. So we do a detailed assessment to understand that. So that would be an extensive investigation. Often it is considered the gold standard investigations when it comes to sleep disorders. Other than that, we do have some specific tests, something called multiple sleep latency test, which is primarily used for people with something like a hypersomnia, where people is sleeping more than required or sleeping in very inappropriate times. We do have that. So these play a huge role in understanding what type of sleep disorder a person has. Depends. If it can be surgically rectified, that's one of the possibility. Other than that, there are certain lifestyle changes a person can do for sure. When it comes to snoring, probably losing the abdomen fat or changing the sleep position can be conservative measures. If when all of it, certain surgeries might not completely resolve the difficulties, in that they also considered a machine that has positive airway pressure that helps a person have relatively normal breathing and oxygen supply. That can also be a good measure for them.
Where does this sleepwalking, come under, in all these 5, 6 categories that you mentioned?
Sleepwalking or somnambulism comes from the parasomnias, where a person is in the non-dream sleep, where where the muscle tone is maintained, but the brain activity is supposed to be completely absent. That's what we understand. That's the reason whenever somebody does sleepwalking, they have absolutely no recollection. So what makes it abnormal is the fact that their muscle tone is maintained and they're actually doing some activity. So this is where it comes under, and this can be quite dangerous because the reason is many people who do sleepwalking are even seen to do complex tasks as driving a car. So
When they are sleeping, they can drive a car.
That's correct.
Oh my God. Okay.
So in fact, so that is the reason if somebody has resulted in an accident due to it, it's legally mandated they have to seek treatment.
So this is happening not in the dream stage. This is happening in the non-dreaming stage of the sleep that happens. Is there treatment for this?
Definitely, there is.
How do you treat them?
When it comes to that, there is conservative measures. Other conservative measures I'll go with as simple as sleep hygiene comes into play when it comes to overall sleep disorders. If the conservative measures doesn't work, I would definitely prefer something like a cognitive behavioral therapy for insomnia. That would be the next step, logical step. If that doesn't work, I would definitely suggest medical treatments. Medications would be the way to go about it. Even though medications are not a permanent solution, until we normalize a person's sleep cycle and slowly wean them off the medication, it would definitely make a good treatment.
When do you call it's a more sleep? What is the amount of sleep that is considered more inappropriate? One is a sleep deprivation, insomnias, that is the other side. But you also mentioned as part of the sleep disorders, person can sleep excessively and have problem. When do you, I mean, when do you call this as a sleep disorder when person is sleeping more? What are the criterias? And what is the reason? What are the reasons for these people to have more sleep?
So the reason for that would be among the chemical messengers in the brain which keeps us awake. One of them is called orexin or hypocretin. Whenever this molecule is absent or less in amount, it can result in sudden episodes of sleepiness. When I say more, it's not just the duration, it's all about being inappropriate. I would not expect a person to sleep when he's driving or when they're doing office work. So they have the sudden episodes of sleep where they go into dream sleep suddenly, then they wake up, then they feel refreshed. That sleep might last for about 10 to 15 minutes, but is definitely in inappropriate places. That can be considered excessive sleep. And when it comes to this particular condition that's called narcolepsy, there are other features that coincide with it. One thing would be the fact that they might have a condition called cataplexy, where there is any emotional uh, stimulus can result in them sudden loss of muscle tone. It can be either partial or complete. They usually completely fall to the ground, or either the facial muscle give up or the arms give up. One of the part of the body completely gives up. Other features constitute something like a hallucination, hypnagogic hallucination, where when they're going to sleep, they see vivid imagery. Third thing would be they might also experience sleep paralysis. They're awake, but they're unable to move their muscles. All this constitutes narcolepsy, and that might be considered very inappropriate.
Okay. What do you, advise, what is your opinion to those people who take alcohol or some form of drugs or try to self-medicate when they feel that they're not getting sleep, or they just want to, avoid a particular situation? When you're stressed out and you're not getting sleep because the same repetitive thoughts and that, unpleasant thoughts are coming back to you, you want to numb yourself, and the person just gets into these things, one of those drugs. What do you suggest? Is it okay once in a while I don't get sleep, have a drink and go to bed?
I can understand why a person might resort to alcohol when they feel anxious, they're having difficulty with sleep, unable to go to sleep. I can understand as to why they might self-medicate themselves, because based on their prior experiences, they know alcohol is help them induce sleep, but it is definitely not suggestible for many reasons. Firstly, it's understandable if a person is feeling anxious, that is, and are unable to sleep, that is because their chemical called GABA is less in amount. So it's understandable they'll feel the need to use alcohol, which does increase that particular chemical that induces sleep and also acts as a very good anxiolytic or something that dissipates their anxiety. So it helps them with a smooth sleep. But the problem that is when it comes to any substances, including alcohol, does come drastically change the sleep architecture as to what a normal the sleep cycles we discuss from N1 to N2 to N3, then REM, then going back to N2. This particular there's a normal sleep cycle, the ultradian cycle that happens, it's completely altered. What happens when it comes to a person with alcohol is their initial part of the sleep is predominantly deficient of the dream sleep, and the later part is dominated by the REM sleep. So to the point that when a person wakes up, they'll still feel anxious, even more anxious than they went to sleep. So it becomes a vicious circle where they find solution again with alcohol. Alcohol, as we know, can result in tolerance, where if a person has to have the same effect from the alcohol, they have to keep increasing the amount. So this vicious cycle results in more sleep problems than it solves. And it's the same goes for with cannabis. There's not a single substance I can think of that preserves the sleep architecture. Everything hampers sleep architecture. On the long term, it's a very bad solution.
Yeah, absolutely. And from a psychiatrist point of view, if you've come across or if a patient comes to you, what are the treatment options that you have? like medicines and what else you do, what else as a patient they can expect when they come and meet you for so many sleep disorders that we spoke about.
I'll definitely try to understand as to if the sleep difficulty they're having is happening with adequate opportunities. That's the first thing I'll try to understand. As in, have they given room for a good sleep? It might be that's where sleep hygiene comes into play. I request them with respect to maintaining certain discipline. That might be as simple as refraining from stimulants like coffee after 4 p.m. Or if they do use tobacco, kindly to refrain from using tobacco 1 to 2 hours prior to sleep. And one of the most important aspect I've seen in with many housewives is the fact that they say after their lunch they take a nap for an hour or two, which is completely not advised. As we were discussing before, there is some accumulation of sleep-inducing elements called somnogens. In one of the famous one is adenosine. When it keeps accumulating, we go to the tip over point. The urge to sleep is there, but what happens if they take a daytime sleep is the urge dissipates. So it's understandable. Many people say, I don't feel like sleeping because you slept in afternoon. So I definitely do not suggest because it changes the sleep architecture altogether.
So we are talking about sleep hygiene right now.
Yeah.
Yes. Yeah.
So I would definitely tell them to avoid taking naps in the afternoon and also refraining from screen activities 1 to 2 hours prior to this normal.
I think this is the most challenging, of all the suggestions till now, whatever you have made. We are so hooked onto our mobile and screen, uh, even just before going to bed, I think we just want to see if there was any lost message and then only go to bed. But yes,
That's definitely to understand as to why the screen has such adverse influence. We probably have to understand as to when we discuss about circadian rhythm, the internal clock. The internal clock is maintained by a part of the brain called suprachiasmatic nucleus, where the internal clock is seen, as I said, the outside cues are taken into consideration. It might be the exposure to light. So normally, until very recently, 30 years back, when we switch off the light, like, that's done and done. And the sunlight was the other cue we had. Unfortunately, in the last 20 to 30 years, we have had devices which has significant amount of blue light, which gives the false impression to the brain that it's still day. So the melatonin that is supposed to be produced in the absence of light does not come into play. That's the reason it's very common for us. A lot of people are using melatonin to supplement their film, self-medicate, and not letting their natural melatonin cycle to kick in. So screen time is something that they have to avoid for sure. And also, there's one more part of sleep hygiene called stimulus control. What I mean by that is the fact that before going to bed, for an hour or two, we should stop all our previous doing activities. We should help our body and mind wind down for a while and then go to bed. And certainly, the bed should not be used for any other activities like watching movies, texting, reading books. Ideally, none of it. Ideally, the bed reading, definitely. I would expect them at least to be having sound sleep for more than 8.5 hours, or 85% of the sleep should be achieved through the 10 hours. That's the efficacy. So if it is less than 85, they're supposed to decrease the sleep timings by about 15 minutes and try to see if they meet the efficacy. If they still don't meet 85%, decrease by 15 minutes. So basically ensure no matter how much you're sleeping on the bed, at least 85% should be of sound sleep. If they meet the sweet spot, then they can slowly increase the timings again. So the idea is that sleep should be consolidated. It should not be fragmented. It should not be in multiple times. It should not be with a daytime nap. So that's not the way to go about it. So when you practice all these aspects of sleep hygiene, your sleep should soundly increase. So if this does not help, usually I also request them for going for something called as cognitive behavior therapy. For
I think before you get into the core treatment part of it, something related to the sleep hygiene part of it, people generally say that I prefer going to the gym in the evening so that I'm exhausted and I just knock out, when I'm on the bed. Is it good?
Not at all, because sleep exercise always is suggested in the morning. When you do exercise in the evening, we are basically putting your body through a state of kind of a stress where your heart rate increases, your respiration increases, your metabolism increases, and there are certain chemicals like adrenaline, norepinephrine, basically it increases, and that is not good for starting the sleep. So when you're activating so much, it's extremely hard for your body to be active couple hours back and go to a deep sleep few hours later on. So it's
Prefer this physical activity in the morning, as soon as you get up, not before going to bed.
in fact, it might make sense, right? If the person is having norepinephrine in the morning, with the natural uptick of the norepinephrine, they'll feel very active throughout the day.
Yes.
If a person with significant anxious thought might not be benefited by trying to close their eyes and wind down, but for most people, it's understandable. What they're telling is, what they're suggesting is more of a meditative state where they have to let the thoughts come out, and it's a cathartic process. And usually, when it all expressed, they can go to sleep in a sound fashion. So that might be helpful for a lot of people, for sure.
Great. I think we were talking. You are talking about different treatment aspects, and before, as I understand, before any treatment begins, please look at the sleep hygiene. And the sleep hygiene is what you just mentioned. So all of it, I'm trying or I've failed on these things. Now what? What are the treatment options that is there?
When it comes to the treatment option, the CBTI, the cognitive behavioral therapy for insomnia,
Are there medicines for sleep?
Definitely, but I would definitely consider CBTI first.
First, okay.
Because the evidence shows that when it comes to medications, if the medications are taken for a period of anywhere between 8 weeks to 12 weeks, about 2 to 3 months, after that there is still a small risk of them not having natural sleep right away. The benefits might not last significantly, but when it comes to CBTI, it's definitely seen even after the duration of the therapy, the sleep continues to be improved all throughout. CBTI is, in fact, people can avail it as a free of cost from their phones, but I would suggest against it for this particular reason. I'm trying to help people stay away from the screen. I can't find the problem and the solution in the same place. So I would not suggest that. I definitely would expect them to probably consult a specialist of the same who helps them understand their sleep, helps them record their sleep for about 2 weeks, have a detailed understanding of how to help them and loosen any bad habits they might have, and what kind of thinking patterns, as you're suggesting, with respect to they might have certain thoughts, let them body mind rest and go to sleep. A specialist might be able to help guide them better as to how to guide their thinking, hence the behavior. So CBTI is something we should consider before the medication. And coming to the medications, even though not a single medication might preserve the normal sleep architecture, that is something I would still suggest, because whenever we think of medications, it's always been risk versus benefit. We'll see how the client's current sleep architecture is, how the sleep habits has been, and what kind of influence does the medication have on it. An expert can definitely guide them from having a drastically abnormal sleep to relatively normal sleep to slow, gradual reduction of the medication. So medication is definitely suggested, but for different conditions, depending on the causes, we address the medication.
So broadly, from the treatment context, there are medicines, as you rightly said, would prefer that to be an option to be kept only after some amount of psychological work and sleep hygiene is taken care. Apart from these two, are there any other treatment modalities
For insomnia,
insomnias or this treatment, I mean, sleep disorders?
uh, uh, sorry, sir.
So are there any other treatment?
No, you're talking about something like a CPAP?
Yeah, I mean, whatever is there anything else at all, the neurofeedback or anything that is there, apart from these two? Nothing. You can say that, you can say the same thing.
I'm not aware of. I'm not aware of any other interventions, particularly addressing the primary cause. Has always been the main part of the treatment.
Totally agree. Totally agree. So, our Cadabam's Insight research team, they have collected few questions, which are the myths or people have some wrong ideas about the sleep. So we want you to answer in short. Okay, shorter answers is what we expect, And here goes the questions. Your body gets used to lack of sleep?
Totally not true. It is not true to point that the current statistics in India is more than almost 60% of the individuals in India are having less than 6 hours per sleep, like 6 hours or lesser. And a lot of people still have this notion that even with less sleep, I can just manage my work. It is seen, it is the people who are having less than 5 hours are working with the same functionality as a person who is legally drunk. How a person who is drunk has the same confidence, I can drive fine, they still have the same confidence, they can function through with it. When it comes to complex tasks, it is shown that they will not be able to do it. So we will not be able to function with less sleep.
Snoring is harmless.
Snoring is in fact, the snoring is definitely harmful. It is a good signifier that there is a restriction, there is some friction happening in the way we are breathing.
It needs to be
It needs to be addressed.
it needs to be addressed. Napping makes up for poor nightmare sleep.
No, in fact, napping again changes the sleep architecture and it results in further poor sleep in the night.
Only overweight people have sleep apneas.
That is one part of it. But the second part of it, there are people with central sleep apnea where the brain is unable to coordinate all the breathing muscles. So the overweight is not mandatory that person to have sleep.
Brain shuts down while you're asleep.
Not at all.
No snoring means no sleep apnea.
Not true. So as I said, central sleep apneas might not always present with snoring, but they'll still have episodes they're unable to breathe properly.
Lab studies are the only way to diagnose sleep problems.
Not really. In India, we do not have such facilities prevalent everywhere. So a good clinical examination will play a huger role than lab studies.
Sleep disorders or problems are not so serious. It's okay.
No, sleep disorders on a long term can result to all type of mental and physical illness, so it should be taken into consideration.
Thank you so much. I think today we have had a wonderful interaction. One of the basic aspects of our life, sleep, which we consider we know it and we have understood it and we don't care about it. But talking to Dr. Thejus has been enlightening that sleep is such an important aspect of our life and its positive effects, why we should sleep. And when we sleep well, how health is preserved. And when we don't sleep, what happens to our body, physical health, mental health, and what are the different types of sleep problems, when to approach a psychiatrist, when to approach a medical professional, and what are the treatment options. So if any one of you think you might have anything to do with sleep, you want to understand more, you have problems with sleep, do not sit at home and dream. Meet the professional and professionals will be able to help you. Thank you so much, Dr. Thejus. It was wonderful interacting with you and you are so crisp in your answers and thank you.
Thanks a lot, sir. Thank you for the opportunity.